we would like to welcome you to the 2018 annual meeting of the American Academy of Neurology in Los Angeles, California. This is the world's largest gathering of neurologists with more than 10,000 neurologists and neuroscience professionals in attendance. They're here to learn and share the latest scientific research advances in brain disease. My name is Andy Imholt, and I'll be moderating today's press conference. We're joined by members of the press here in attendance at the annual meeting and by conference call. Today, I welcome Dr. Alexander Rae-Grant and Dr. Ruth Ann Marrie, authors of the American Academy of Neurology's Practice Guideline, Disease-Modifying Therapies for Adults with Multiple Sclerosis. The guideline was endorsed by the Multiple Sclerosis Association of America and the National Multiple Sclerosis Society. The research will be published this afternoon in the online edition of Neurology, the medical journal of the American Academy of Neurology, and is strictly embargoed until 4 p.m. Eastern Time, 1 p.m. Pacific Time, Monday, April 23rd. It will also be published in the April 24th, 2018 edition of Neurology. Dr. Rae-Grant is a board-certified staff neurologist and a professor of medicine at the Cleveland Clinic Lerner College of Medicine. He is also prior medical director of the Center for Continuing Education at the Cleveland Clinic in Ohio, and he recently accepted a part-time position with EBSCO Information Services. Dr. Rae-Grant's area of expertise is in multiple sclerosis and related disorders. He has authored multiple textbooks in neurology and multiple sclerosis and serves on the Guideline Development, Dissemination, and Implementation Committee at the American Academy of Neurology. Dr. Marrie is a professor of medicine and community health services at the University of Manitoba. She serves as director of the Multiple Sclerosis Clinic and holds the Waugh Family Chair in Multiple Sclerosis. Her clinical interests are in multiple sclerosis, and her research focuses on the epidemiology of MS and the impact of comorbid conditions on the outcomes in MS. After our lead author's presentation today, we'll take questions first by those in attendance here in Los Angeles and then by journalists on the phone. Please remember to identify yourself and your media outlet when asking questions. Just a reminder again, there is an embargo on this presentation of 4 p.m. Eastern Time, 1 p.m. Pacific Time today, Monday, April 23rd, and a video of this press conference will be posted on YouTube tomorrow. Welcome, Dr. Rae-Grant and Dr. Marrie.
Thank you, Andy. Yeah, thanks, Andy, and thanks, members of the press, for coming to this press conference. So we're very excited about this guideline, which was a large group effort from multiple people. I'll just say a few words. Disease-modifying therapies are drugs that alter or change the course of multiple sclerosis. Unlike some treatments which can only help manage symptoms, disease-modifying therapies are not a cure, but they can reduce the number of relapses that a person with multiple sclerosis has and change how the disease affects their course over time by slowing the disease process. The treatment landscape for people with multiple sclerosis has changed dramatically in the past decade. We now have many disease-modifying therapies from which to choose. So the American Academy of Neurology has issued the new guideline on disease-modifying therapy in MS, which is published online in Neurology and endorsed by the Multiple Sclerosis Association of America and the National MS Society.
Multiple sclerosis is a leading cause of non-traumatic disability among young adults. It's a chronic inflammatory condition that affects the central nervous system, causing substantial disability and increasing the risk of mortality. For this guideline, we carefully reviewed available scientific studies on the use of MS drugs. We found that for most people, it is better to start taking drugs for multiple sclerosis early on rather than letting the disease run its course. This is because the disease is known to get worse over time. According to this guideline, several MS drugs have either strong or moderate evidence supporting their use for slowing certain disease processes.
While multiple sclerosis drugs may help slow and stabilize the disease process, some people with MS may experience a return of disease activity while using an MS drug. According to the guideline, if that happens, patients may need to switch to another MS drug shown to have less risk of returning disease activity. Also, some people whose MS is stable may think about stopping their MS drug use since they have no signs of disease activity. But our guideline found that there was very little information on benefits or risk of stopping MS drugs. Currently, there is no blood test that can determine whether a person's MS drug is working. There's no universally accepted method to determine which MS drugs to use, in which order, or in which patient.
Some MS drugs have risks for the reproductive health of both men and women, and the guideline offers recommendations regarding pregnancy and disease-modifying therapies for women with MS, including that their doctors monitor any plans for pregnancy. It's important to be aware of the potential risks of these medications, and we recommend that people weigh the benefits and risks with their physician before deciding to start, switch, or stop using an MS drug.
Thank you, Drs. Rae-Grant and Dr. Marrie. We will now take questions from reporters in attendance. Oh, hold on, we'll get the microphone to you right there. Thank you, Lynn.
So what's new in the guideline? I mean, what is changing and what
So
does it say?
a number of new things in the guideline. First of all, the last guideline was 2002, and we only had a handful of MS medicines at the time. We now have 17 or so FDA-approved medicines with other medicines used off-label. So it's a dramatically different landscape of the choices that clinicians have to make. In addition, there's more choices in terms of side effects and route of administration, some new pills, some new infusions. And so the landscape for clinicians is very complicated and makes life very hard in terms of making decisions. The other major new change was that since the last guideline, treatments have been directed at patients with a very first episode of demyelination, even before they've had a formal diagnosis of MS. We now know that treating earlier is better in terms of reducing the number of new relapses, reducing the chance of having more injury to the brain. So these are some dramatic changes in terms of what we have to provide to people with MS.
Dan Keller, Roularta. How specific are the guidelines? There's a big question among patients and physicians about, well, where do I begin? Which drugs, what sequence, what do I switch to? So how specific are they? I know they're not a protocol and just guidelines, but how specific?
Well, the guidelines are really just that, they're guidance. So the guidelines provide and are supported by a systematic review of evidence regarding the different medications. And they encourage clinicians and patients to have a detailed discussion about the risks and benefits of the different therapies, to evaluate patient preferences about whether they prefer oral therapies, once-a-day therapies, once-weekly therapies, and those kinds of considerations. So emphasize that you need to have that informed, fulsome discussion to share decision-making, but doesn't say that for an individual that you should take this drug. It provides the information about the available therapies so that each clinician-patient dyad can use the information specific to that patient to make the best decision for that particular scenario.
Lynn Peterson with Trends in Medicine again. So are you not making any recommendations? Other societies that are putting out guidelines now this year are actually doing priorities. We would prioritize the use of the drugs in such a way. Are you not doing that at all?
So if you look at the evidence, there's very little evidence to decide which drug to use at what time. Our guideline process is based firmly, but not entirely, in the evidence. So we may have a different process than other societies in terms of how we come to a decision about recommendations. So we did not provide recommendations for a particular medication in the initial starting of medications. When we look at subgroups of patients with highly active MS, where they're very aggressive disease, we did have some specific medications, but this was again based on the systematic review evidence that we had and based on studies that were done, particularly in those populations. We really tie it very closely to the evidence.
Dr. Anthony Alesi, CBS Radio. One question, in looking at the guidelines, one of the struggles we all have with guidelines is the cost of the medication. Was that taken into consideration when putting these guidelines together?
So with respect to reviewing the evidence, of course, that didn't play into the determination about the strength of the evidence. But there is a specific recommendation within the guideline that allows the consideration for people who may not have access for financial reasons to some of the therapies to consider off-label use of a couple of medications, specifically azathioprine and cladribine. The guideline also points clinicians to think about some of the sources where patients might be able to get financial assistance with access to medications, recognizing that this is a substantial concern for many individuals with MS.
Susan Jeffrey from Medscape Neurology. I wondered, there have been just in the past couple of weeks some developments on diclizumab and some of the new risks that came out about alemtuzumab. I wondered if you had the opportunity to incorporate those in the evidence that you reviewed, and also what gaps do you see, like what future research would help you in reviewing this guideline again in future?
All right, so two questions. The first one, we did incorporate the Biogen withdrawal, voluntary withdrawal of diclizumab from the marketplace, though we left the systematic review information in the body of the systematic review, but we did make a comment about that. We have a number of points about alemtuzumab, in fact, all the medicines in terms of safety analysis. Our systematic review finished in November 2016, so there are certain kinds of things we can't just keep adding to a guideline. It's part of the guideline process. The second question was, what about future research? And there were a number of areas that we did recommend for future research, particularly comparisons of strategies for treatment, a strategy of starting with low risk, maybe lower efficacy drugs versus strongest, most robust medication initially. That really hasn't been well studied before. Comparative efficacy research in terms of comparing different drugs in the marketplace. So there are a number of other things that we thought should be part of future research, which is part of the documents.
Hi, Hemimaki from Sage Publishing. What would you say are the key differences and similarities between this and the AAN ACTRIMS guideline that was published last year?
So there are several differences between the two guidelines. I think the first thing to remember before one thinks about some of those differences is there are some slight differences in the process in terms of who was involved in the guideline development, what was incorporated in terms of the evidence that could be reviewed, and that there are different regulatory environments between the United States and Europe. In broad strokes, I think the guidelines share some strong similarities in terms of the recommendations for early use of disease-modifying therapy, maintaining therapy in terms of individuals who are responding well to therapy, and recommending switches of therapy in individuals who appear not to be responding on the basis of, for instance, breakthrough relapses and changes on MRI. There are some slight differences in tone around some specific medications. So, for instance, mitoxantrone, for example, where there's a bit more concern in our guideline regarding the safety of that medication and its use. And I think there are some differences as well in terms of recommendations around pregnancy, where the AAN guideline is more conservative in terms of some of those strategies. But I think to a large degree, beyond the methodological differences, any differences that arise here reflect gaps in knowledge where there's some decision that has to be made about an interpretation and recommendation in the absence of all the available evidence that we would like. As Dr. Rae-Grant has previously mentioned, there are some areas where we don't know all of the answers, and so both guidelines allowed experts to make some recommendations based on the evidence, but to provide some context, because our clinical trials don't exactly answer the question in clinical practice. It doesn't say if you have this person in front of you who's 30 years old with these problems, this is what you do. So there were some slight differences in interpretation at that level.
Hi, John O'Trompe with The Lancet. I understand you revised your classification system around 2016, if I remember correctly. How many new drugs have become available for MS since 2016?
drugs? Well, it depends on, so teclistamab came out but it was withdrawn. Alemtuzumab was somewhat before that. What else have we got? Plegridy's relatively new. That's one of the interferons. The classification scheme is always modified over time in our process. The GDDI committee has an ongoing update of classification. For therapeutic drugs, it's usually a limited change in terms of what goes on. It's more other aspects of the process. So I don't think the dating of the classification scheme would not make us do anything tremendously different in terms of how we rated the medications or the studies that they're involved with.
Anyone else? Oh, last question.
I could do this. So when you talk about switching, can you describe a little bit about the switching between natalizumab and fingolimod?
So we had quite a bit of information about natalizumab, and particularly because there was a rich literature on various aspects of monitoring and use of that medication. The reason we mentioned fingolimod was because there was a switching study done, and there was a time window that seemed to be more optimal in terms of making that switch. Whether or not there's other medications which are appropriate for the switch is, again, a place for future research. So we were bounded by the available literature on that particular topic.
Hi, Susan Jeffrey again. I just was wondering what, with the competitive landscape of this many drugs, how do you get comparative information that you need? I mean, is the hope that there'll be, you know, sort of NIH-funded kind of trials, or what lies ahead for that?
Well, I think we all agree that comparative effectiveness studies are important, and there are a number of mechanisms to do them. You're right that it may not always be done by a pharmaceutical company in comparing its drug to another agent, although that's certainly where we have some of the available evidence. But investigators often initiate these kinds of studies because these are the questions that they need answered in clinical practice, and so NIH is one potential funding source. Disease-specific societies such as the National MS Society and other organizations may also step forward. PCORI is another potential source of funding, so I think increasingly, as we recognize these are important gaps, investigators will need to step forward and answer these questions.
I'll just add, PCORI is funding some studies which directly deal with comparative effectiveness and also different strategies. So some of the things that we recommended as future research is now in process.
Okay, we have one final question, and then we're going to take questions from the phone.
Hi, I'm Jenny Smith, Clinical Neurology News, and I was wondering, when you talk about the patient-physician relationship, you recommend in these guidelines that there be a dedicated appointment to discuss starting a DMT and that it not occur at the time of diagnosis. Can you explain that, and I can imagine some potential pitfalls for that as well, so just wondering if you could justify that.
Yes, thank you. So that was a large area of discussion with our panel, and I would like to say that the panel incorporates experts in the area of multiple sclerosis, but also experts in methodology and experts in terms of guideline development. The reason for that is there's a reasonable literature, not necessarily just from MS, but from other major diagnoses, that at the time of a diagnosis, what people with the diagnosis hear is often zero afterwards. And there's this dull roaring in their ears for some time. And it's such a weighty decision in terms of deciding which medication, we did feel it was an important recommendation to clinicians to do that at a different time. Now, often if people are coming to an MS specialist or to a MS clinic, they may already have the diagnosis. So obviously that would have been a prior visit and not necessary to wait for it. But that was the reasoning for that.
All right. Thank you. We're going to now take questions.
The conference has been unmuted.
Now, are there any questions from anyone on the conference call line? Hearing none.
The conference has been muted.
On behalf of the American Academy of Neurology, I'd like to thank Dr. Rae-Grant and Dr. Marrie and the members of the media for attending today. For more information about the American Academy of Neurology's guideline on disease-modifying therapies for MS, please visit AAN.com. That's AAN.com. For the American Academy of Neurology, I'm Andy Imholt. Thank you.